Hello, welcome back. Today we will be diving into quite an interesting topic. But first, let's go through the types of cytogenetic testing. You don't require to know the nitty-gritty of every single type, but what's important is to know the applications of the types of cytogenetics testing, right? So everything for the cytogenetic testing is really to help identify what kind of genetic disorder the patient is suffering from, or to like do some prenatal testing, or to test the genotype of both the mother and the father to give them a prediction of what kind of cytogenetic or genetic disorder that their child might be prone to. This is not to say this is to recommend abortion or any other sort of in utero treatment, but this is to just prepare the parents, and if there's treatment available, these are steps that they can take and look into. But the most common is really just banding, and you stain the chromosome with GEMSA stain, and that is it produces like a black and white karyotype. This is the most common because it is the most cost efficient and it's the fastest. You can get this within like a day. What's important about the banding is that you can compare the bands with each other and see which part of the chromosomes are deleted. So this is good to identify deletions. The stains will bind richly to the AT region, and there's something called a reverse staining, and it's the same process. You still stain with the GEMSA stain, but the all of the material is put in a hot phosphate bath before staining. The spectral karyotype are these when the DNA is tagged with a fluorescent tag or a fluorescent dye, and then rearranged in the ideogram. And the spectral karyotype is really important to see triploidy or aneuploidy because the colors will, of course, make it far easier to see. So if there's like an extra like dark green, that would be this would be a trisomy of this. And what if there's like a little trunk right here of blue? That would be a triploid of this chromosome. And then the M-fish is a banding technique, really, and it's important to see the translocations, in particular translocations that are kind of hard to see on the GEMSA stain. As you can see here, there's a translocation from here. Like this yellow bit should be on this, and this blue bit should be here. Right here is missing a tiny bit of the blue, and this should be on the pink chromosome. And these are really seen more in research because these are quite expensive, and the results do take a while to come in, like a week or so. Okay, here's the more interesting things. Down syndrome, of course. Trisomy 21 is the most common trisomy because it's the most compatible with life. It's the smallest chromosome. So a repeat of that chromosome is more compatible than the repeats of larger chromosomes. As the size of the chromosomes increase, the compatibility with life decreases. So this is linked with maternal age. So women over the age of 40 are not recommended to produce children because the chances of having Down syndrome is much higher. This is associated with the DARK1A gene. This has some kind of role to play in brain development, in cognition, and the Down syndrome patients are also prone to APP. And remember when we were learning about dementia and Alzheimer, this is the plaque, the amyloid beta precursor protein. And an accumulation of this will lead to the Alzheimer disease. So not every person with Down syndrome has like very very severe symptoms. It depends on the penetrance, and that is because of the amount that is replicated. If it's a full replication, the patient will be suffering from very extreme symptoms. If it's only a partial replication, the only thing they might have is some developmental delays, some issues with like the heart, but things that we can treat relatively simply today in the 21st century. So the associated symptoms, of course, is Alzheimer, heart disease. They have some heart defects, gastrointestinal disease, thyroid dysfunction, diabetes. This is why most Down syndrome patients are prone to obesity, and these are the most common physical symptoms. Like the occiput, or the back of the head, is going to be flat. The ears are going to be kind of like low and abnormal. More importantly, there's going to be something called like a simian crease. So it's just one long transverse crease on the palm. If you look at your own palm, there's many lines, right? But these patients do not. They do have occasionally like an umbilical hernia, but in most patients they have like hypotonia and toes that are widely spaced. But those are kind of like rare. What's like most common is the facies. Has a broad, flat face, the slanting of the eye, like a small eyes too, a short nose, and it's usually upturned. And the small arched palate. This is a little wrong. The tongue itself is not big, but the mouth is small, so it seems like the tongue is abnormally large. Edwards syndrome is the trisomy 18. It's the second most common autosomal trisomy, but it's still not very common. This mostly affects females because the males die before birth. It also depends on maternal age. The older the woman is, the higher the chances of having Edwards syndrome in their kids. This is much more severe than Down syndrome. This severely affects all of the organ systems, and thus it has a very low rate of survival. Some of the complications would be like kidney malformation, severe structural heart defects, the intestines protrusions, feeding and breathing difficulties. As you can see, it's because they have a very small jaw, a small mouth, a short neck. Unlike Down syndrome with a flat occiput, this has a prominent occiput. It has a shield chest, which means it's a very short and very prominent sternum with wide placed nipples. It has the malformed ears, usually a little low slung. And for this one, it usually has the clenched hands with overlapping fingers. It's important to note the overlapping fingers because most babies do have clenched hands when they're born. They have a flexed big toe, but they have something called rocker bottom feet. Look, it's abnormal. They do have a somewhat distinctive face. It's like it looks like most of their facial features are just like concentrated in the lower part of their face with a prominent forehead. And look at these low slung ears. Patel syndrome is by far the most dangerous. It's the rarest. It's a trisomy 13, and 13 has a, it's larger than the other chromosomes that have been triplicated. It's associated with severe neurological and heart defects. This usually affects females, but most of the fetuses just die very early, within days or weeks after birth. Of course, it's associated with increased maternal age, and though it has very similar symptoms to Edwards syndrome, instead they have polydactyly, which is extra fingers. Microcephaly means their head is very small, or holoproencephaly. or an absent nose, or microphthalmia, which is like tiny eyes. Okay, let's go into holoprosencephaly a little bit more. So during development, the brain hemispheres will split, so we can have the left and the right. In these unfortunate patients, it does not split. So look at this face. Look at the symmetry, but look how close the eyes are. Look how abnormally large they are. It's because the head is small, not because the eyes are large. It's the head is abnormally small, and they're very, very close together. There's no nose bridge to speak of because the brain didn't split, and neither did the face. So the brain has to divide, and then that will induce the somites, so the mesoderm and the ectoderm, to also divide and split into the two halves of the face. Here, look at this. This is a very bad cleft palate. It's hardly formed at all. Couldn't really consider this like a cleft lip. There just isn't any lip. The eyes are very small right here, and there's no nose to speak of. This child will have a lot of problems just feeding and breathing in general. That's why they're crying. So these patients also are associated with heart and kidney defects, because if the brain didn't divide into the left and right axes, like neither do the kidneys, and the heart could be formed on like the wrong side of the chest, and it might be like dextrocardia. That might happen to these patients, but this is very, very rare. It's just very unfortunate. So Cry-Du-Cat is a 5p deletion. It's also known as Lejeune's syndrome, and this is fairly common. It usually occurs because of a de novo deletion, so there's not really a genetic component of it, or there's not really like a inherited problem, right? They have a characteristically high-pitched cry due to their underdeveloped larynx. I'm going to try to make it for you right now, but just imagine your head like it's like a kitten's cry, right? So it's like it's very like short and forceful, because the babies cannot cry normally, right? But the deletions are more frequent in the females. And the symptoms include like hypotonia, microcephaly, delay in developmental milestones, cardiac defects, low set ears, hypotonia. Oh, I said that twice. I'm sorry. But like a flat facial profile. It's like very round too. They also have the simian crease, and a big gap between the first and second toes. And they are like, they're not as severely affected as the other trisomies, because it depends on how much is deleted. If it's like only a minor deletion, then the child might have some learning disabilities, but not all of them are very severe. Not all of them have like the microcephaly. Say like this child is fairly normal. These patients with Cry-Du-Chat syndrome is also fertile, so they can reproduce. Okay, so Angelman syndrome. So remember, like, this is how I remember it. Angel is mom. So I remember this is the association where the maternal contribution to chromosome 15 is deleted. It's caused by a variety of factors. We're not completely sure, but which one is like the major contributor, but it's definitely caused by genomic imprinting or translocations or mutations. It's characterized by intellectual delay, seizures, jerky movement, hand flapping, frequent smiling or laughing. Everybody really knows this is Angelman syndrome, but in older textbooks and like older physicians or outside of the U.S., it can be also called the happy puppet syndrome because of the jerky movements of the arms, and the hand flapping, and they're always laughing, always smiling. So these are like fairly happy patients, but what's characteristic about it is these are inappropriate, smiling or laughing, like during the wrong scenarios. During like a very sad scenario, like a funeral, they might be smiling or laughing, or in the middle of like grocery shopping, they might burst into spontaneous laughter. It's also associated with the UB3A, UB3, no, sorry, UBE3A gene, which affects the pattern of methylation. And remember, methylation is the silencing of gene. So with that silence, it's around like 4 megabyte deletion, or megabase. I'm sorry, I'm thinking about computers. Around a 4 megabase deletion. So it's quite a bit that is deleted. These children are also associated with edema in the hands. This is the normal child's hand. Here, this is edema. This is not just them being a little chubby. They're also like characterized facially by like a very prominent nose. The reason why they have the jerky motions and the seizures is that they have some problems with their coordination and balance. To them, it feels like the world is always in motion, so it's like a constant earthquake. That's why they have the jerky motions. Oh, I forgot to mention that in Credichat syndrome, these children cry all the time because of their hypotonia. In severe cases, the hypotonia is just very uncomfortable, very painful, and they're not able to shift in the bed or in the crib to a more comfortable position. So that's why they're crying. They're very uncomfortable and they're in pain, and they're babies, so all they can do is cry. And after like the first 2-ish years, they actually develop hypertonia, so they do get like more muscular, and then over time they will balance out, so to speak, and develop normally. Okay, PraterWillie is how 7 genes on chromosome 15, again, remember, are deleted or unexpressed on the paternal chromosome this time. So Angelman and PraterWillie, they're both on chromosome 15, but PraterWillie, I just remember as Pater, so it's the deletion of the paternal contribution. Unlike Angelman syndrome, this one has like hypotonia as one of the symptoms, short stature, incomplete sexual development, cognitive disability. The more like worrisome clinical feature is that they have a regular and excessive hunger, like extreme hunger, and it leads to obesity. So look at this child right here. This is not normal. It's one thing for a child to be like overweight, but it's another thing when the child, like at age 5, is morbidly obese. So they do have some problems with like impulse control as well, because the hunger just kind of overrides everything, and all they want to do is eat. So that can kind of lead to a false diagnosis of like autism, or like an impulse control kind of issue, and these children might be sent to like counseling, or put on those kind of medications like ADHD or ADD medication, but that does not work because that's not the true problem. So if you see a patient who is acting out with that is very, very obese at a young age, and try to consider that perhaps this person suffers from Prader-Willi syndrome. This is treated with daily recombinant growth hormone injections to overcome the short stature and to complete the sexual development. But the hunger is really the issue. You can modify it with like behavioral training, and there's a couple medications that can like antagonize like ghrelin, the hunger hormones, and try to satiate the patient. Thymic Appalachia means that the thymus is not developed. It's called DeGeorge's syndrome, and it's the deletion of, importantly, the TBX1 gene. That's the thymus gene, and 20 to 30 other genes on chromosome 22. And the features vary widely, even among the members of the same family. So this is like a little bit like genetically linked. It's associated with some congenital heart diseases, the cleft palates, cleft defects, neuromuscular problems, learning disability, and mild differences in facial features. So, what's more problematic is there's no thymus, and the T cells are produced in the thymus. So there's going to be some problems with the immune responses, the T cell mediated responses. It's also going to have low levels of parathyroid hormones, so it's going to be some problems with calcium balance in the body. And this is also associated with a 20 to 30 fold risk of schizophrenia. Okay, so we know the sex chromosomes are like, X and Y, and the disorders with the sex chromosomes is going to be more compatible with life compared to the the autosomal disorders, or the disorders where it would be like like a aneuploidy, triploidy of the entire genetic spectrum. Because in females, normally one of the X is inactivated, making a bar body. Methylation of most of the genes in the bar body is the process called lionization. And why is that somewhat useful? Because if you have like an XXX syndrome, most of them are going to be inactivated, so it's compatible with life because you only really need the one chromosome. So the X chromosome is significantly larger than a Y chromosome. It has 900 to 1400 genes and around 5% of the total DNA. The Y chromosome only has 55 genes, or around that amount. So in males, the homologous pairing between the X and Y occurs in prophase 1 of meiosis at the pseudo-autosomal segments. It's in the name, pseudo-autosomal. So though it's on the X chromosome, these parts of the chromosome code for genes that are like similar to like autosome, and also it's passed down genetically similar to like the way autosome like dominance and recession occurs. And in the 6th week is when the primordial germ cells migrate to make the primitive gonads. Okay, so the Y chromosomes contains like TDF and SRY regions, and SRY is going to be the sex-determining region. It encodes a transcription factor to develop the testes in males. And in the testes, the Sertoli cells make the Mullerian inhibitory factors, or the anti-Mullerian hormones, which suppresses the paramesonephric ducts. I want to say the go-to, but the automatic disposition is of the fetus is going to be developing into a female. That's why males have nipples, actually. The automatic just like route to take is to develop as a female, unless you have the Sertoli cells. So most of the body has already developed as a female. We have the nipples, we have the primitive ovaries, but in males with the inhibitory factors, it will make the Mullerian ducts like not atrophy, but turn into, the vesicles for the testes, and then the anti-Mullerian hormone, which just like stop the development into ovaries and start the development into testes. The Leydig cells also help because in the presence of the chorionic gonadotropin, it secretes the androgens that will stimulate these cells and also stimulate the development of the penis. So the Y chromosome also holds these factors, the azoospermia factors, AZFA, AZFN, AZFC, and those code for sperm development along with semen development, and the deletion of any of these can cause azoospermia, of course, which is idiopathic infertility. Unfortunately, there is no treatment for this. Okay, so the X chromosome. If the Y chromosome is absent, the gonadocortex will continue developing into the ovary at the at the 8th week of development. So why that pause, right? The germ cells has already migrated to the primitive gonad area, and during the 6th week, and then there's this 2-week like stop. It's because this is during like another part of the development where the fetus is still in danger of being aborted. So the egg, or like the embryo, wants to make absolutely sure that it's going to start developing into a fetus before committing all of these resources to make the gonads, because during this time brain development is still going on, but any kind of aberration in that development will lead to the abortion. The medulla will regress, the paramesonephric ducts will develop into the female genitalia, and by medulla I mean the kidney medulla, and the oogonia will start to develop, and then it will be arrested in prophase 1. Oh, remember here, this is the section where Menkes syndrome will occur, ATP7A. Remember, that's a copper excretion problem, a copper accumulation problem. And color blinding, this is going to be on the X chromosome, and this is unfortunately going to be passed to the males, because the males are the one with only one X chromosome. Here, this is the region where Duchenne deletion can occur. Here, Alport syndrome. Remember, that's those are like the kidney deficiencies, kidney problems. Hemophilia A, something more common in the Northern European population, especially the British. This is what the royal family really suffers from. Here, this area is Fragile X syndrome. That's because this is a drawing of the chromosome, but in reality, it's like here's the centromere. There'd be like that the P arm, and then the Q arm would be long, but there's going to be like a little stalk, and that would be the fragile X area. Okay, so sex reversal disorders. This is what we know as hermaphroditism, and it's caused by the abnormal crossing over or the recombination during meiosis 1. And the SRY gene might be lost on the Y chromosome and get translocated on an X chromosome. So that would make an XX male with normal male external genitalia. And for the XY female, the SRY region is deleted. And remember, SRY is really the gene that codes for the development of male genitalia. So though there's a Y in the genetic composition, it's going to be a female. It's also known as Swyer syndrome, And there's normal female external genitalia, but with functionless gonads and underdeveloped breasts. So they will have like the clitoris and the labia and the vulva, but they are going to be infertile. That's not the right word. They are going to be sterile. Infertile means that you have the capability to reproduce, but you just don't have enough. Kind of like an infertile male. They will be able to produce sperm, but just not enough to truly like inseminate a woman. So it's rare, but the XY females can have intersex or hermaphroditic features. The methylation of CpG dinucleotides in the promoter region of the genes will cause the X inactivation. But usually the X inactivation is incomplete. There's some genes on the Barr body that still contribute to, like expression. So the genes of the pseudo-autosomal regions and the genes outside of the pseudo-autosomal regions, which have the related copies on the X or on the Y chromosomes, and one of those X's can be epigenetically silenced. Those chromosomes express an exist gene, and the exist RNA will encode non-coding RNA that stays in the nucleus, affecting the gene expression on the Barr body. So there's not going to be too much X chromosomes expressed. So it's not a bad thing for the chromosome to be inactivated. Like, we do require genes to be expressed from the X chromosome, but we don't need all of them. But the problem is when there's going to be a non-random X activation. So during a translocation, the deletion makes the affected X inactivated, and it's not caused by any epigenetics. These will make the isochromosomes, and there's several different kinds of inactivation. There's going to be the balance inactivation, where like the same amount is going to be inactivated, but unfortunately the healthy X is going to be inactivated. We want the two unhealthy X's because we want to like retain the amount of information that has been translocated. So like, for example, the balanced would be like, let's say this has like 100 genes, right? And this one has like 100, and like maybe this one has like 80 genes, right? And the 20 is going to be translocated onto a different chromosome. So this would be the 80 genes, right? And then this would be translocated in here. So this is the missing 20. So the normal 100 would be inactivated, and the diseased pair will be activated because we want to keep the same amount of data, right? So we all know that deletions are more harmful. So the body will try to keep the 100 genes. There's also something called the unbalanced inactivation, which is better because then the healthy X is going to be always activated. We don't want the unbalanced inactivation. We want to keep the whole number, the 100 genes, right? And then translocated chromosomes with inactivated centers are usually just inactivated. Okay, so Klinefelter syndrome are males born with XXY. So there's going to be a non-disjunction of the X chromosome. Not too problematic in a way because one of the X will be silenced, but that the X is not completely silenced, remember? So there's still going to be some contributions from this extra X, and that will lead to hypogonadism, infertility, broad hips, gynecomastia, and more problematic is the elevated amount of female hormones, estradiol, luteinizing hormone, and follicular stimulating hormones. These do exist in males, but not to the extent of the females, right? So this one will produce the hermaphroditic features. Look at this man's hips. Like, these are like womanly hips. Like, here, womanly hips. Usually they have like larger breasts, and look how small the penis is. Like, it's like a micro penis, and that can be incorrectly seen as like a very prominent clitoris. So these males have like weaker muscles, slow motor development, or weak bones due to like the elevated female hormones, and the small external male genitalia. These patients are at risk for autoimmune diseases, diabetes, ulcers, osteopenia and osteoporosis, tumors, lupus, and rheumatoid arthritis. You can treat them with some like androgen supplements, like testosterone shots, and they do really need the like calcium supplements and the vitamin D supplements in order to like strengthen the bones. And the external features can be corrected with plastic surgery. Turner syndrome is the only aneuploidy that's compatible with life. This would be like 45 chromosomes, and it's because it only has one X. So it's usually missing an X chromosome from the father. So these females will lack the secondary sexual characteristics. So they will lack the breasts, and the pubic hair, and axillary hair. They just won't go through that kind of puberty. They also have a shield chest. Remember, it's like a very broad, short chest, and wide, like wide spaced nipples. It's really defined by the webbed neck. Look at this neck. It also has something called cubitus valgus. So that's where the arm is abnormally supinated. Look, it's also like it's like a shotgun arm. As you can see, here's the barrel. Here is the muzzle. Sorry, I'm not very familiar with guns, but and the arm is like abnormally supinated, and yes, the palm will be facing almost like 90 degrees to the body. And at birth, these children will have the swollen hands and feet because of the lymphedema. And there's no intellectual disability. However, these patients do develop some psychosocial anxiety or depression, or body dysmorphia. The body dysmorphia isn't really it's purely like psychological. There is a basis for their body like dysmorphia, for their body image issues, because their bodies do not develop the secondary sex characteristics after like puberty. They will have very rudimentary ovaries. They will not menstruate. They do not have breasts, and they sometimes have like shortened metacarpals, so like a deformed looking hands. They do have some heart conditions, particularly the constriction of the aorta, and not all of them have the facial features, but they all have like the neck feature. Okay, so triple X syndrome is considered the super female syndrome, and this is a normal female. They have normal development and growth, and because of that, the majority of the children are not diagnosed, or women are not diagnosed. They have the two bar bodies, but it's not problematic because the healthy X will be activated. The only problem that they might have is that their children might be triple X, which is not a problem, but the the chances of having a male child as like, you know, XXY is something to be taking into consideration. So patients like this is when we would do the epigenetic testing, or cytogenetic testing, I'm sorry. So the XIYY are the super males. This is normal male in development, growth. This has some association with like learning disabilities, like dyslexia, and they have an increased testosterone level, so they go through puberty faster. They have more intensely masculine characteristics, like a low voice, or like a very, very deep voice, and they tend to be extremely muscular with very little effort at all. That's unfortunately also associated with increased aggression because of the testosterone. And these men are fertile, but their children, like the XXX syndrome, their children might also be affected, and they might have a translocation as well. Okay, I hope that was interesting. That's it for now. Good luck studying.